Wait. Love that lady. All right. Hi, guys. I'm Alex. I think everyone knows that. I am riding along the 75 today for some strange reason, so that's why we're doing it from the living room here. I wanted to start by thanking you guys for this year. This is going to be my last CQI. And conveniently enough, Dr. Richards decided he didn't want to hear me talk one more time, so he's out on vacation. All right. So we're going to dive into it. This is pretty much trauma, since you saw a lot of it. And hopefully we can touch on a couple of kind of high yield points. And if any of these were your cases and you want to add anything or ask questions, just unmute yourselves and go ahead and say whatever you want to say. All right. So this first one, I said we were going to talk about trauma, but this first one is a good reminder that not everything that at first glance appears to be trauma necessarily is. So this was a dispatch for just an unresponsive person arriving on scene on the side of the highway. So when I first read this, I was like, oh, for sure, this is a car crash. But it turns out maybe not. So on I-75 South, there's a 59-year-old female found unresponsive with PD providing CPR compressions. History was obtained from the police officers on scene. They said the patient was found in the front passenger seat of the vehicle, already unresponsive at the time of first contact with PD. They pulled the patient out of the vehicle, began CPR, and administered Narcan. The patient was found supine on the ground, unresponsive, no breathing, no pulse, airway unsecured, eyes equal and unresponsive, unable to assess PMS, and no signs of injury with a GCS of 3. He took over CPR, applied the monitor and pads, assessed the rhythm, showed VFib, and the patient was defibrillated at 360 and CPR was resumed. Got an OPA in, administered some oxygen and bagged the patient, and got an IO in the left humeral head. Got epi through the IO, got a pulse check after 2 minutes, and found that you had ROSC. The patient was intubated and began to prepare for transport. As you were kind of doing that, the patient went back into cardiac arrest with a PEA rhythm, restarted CPR, got them on the backboarded, loaded them in, and got some fluids and re-administered another dose of epi every 4 minutes. In total, the patient got 3 doses. Also got her some sodium bicarb, and it seemed like there was a lot of blood coming from the airway, so needed a decent amount of suctioning. So probably pretty helpful to have had that endotracheal tube in place to be able to help manage that, which is great. Transported to Westchester, continued the resuscitation, but the patient remained in PEA and went to Trauma Bay 1. So again, this person's on the side of the highway. There was no kind of description of if there was any damage to the vehicle. It seems like probably not, but that's the only other piece of information that might have helped to kind of secure for me that this was a medical arrest and not a traumatic arrest, because we do manage them differently according to the protocol, which we'll talk about. But from a medical perspective, I don't have much to add. You got a defibrillated rhythm early on and were able to get ROSC. This is a good reminder that a huge percentage of your patients that you get ROSC in are going to re-arrest, so be prepared for it in your post-ROSC care. Make sure you're kind of continually reassessing, especially when patients go into PEA, right? Because a rate of 60 and PEA could look very much on the monitor like that person's doing just fine. The only difference is they don't have a pulse. So really good reassessments, good medications. The only thing to consider is maybe amiodarone, but you're on the side of the highway and you got everything else done. So I really have no qualms with this at all. And I love that you got an airway adjunct in there early on. We've talked about that a couple of times this year. So the only other thing is you don't have to get a glucose in cardiac arrest. You might have done it in that kind of ROSC period, which is great. But it's not absolutely necessary because it might be wonky regardless. So this was just a good case of kind of like on scene medical cardiac arrest management. So kudos to this group. Okay. So the next case is a motor vehicle accident. A patient was driving in the wrong direction, northbound on the road, and hit a number of vehicles. The vehicle came to rest on its side with the patient laying out of the vehicle. The first people that showed up to the scene were a physician, ER doctor, and crew from a private ambulance. The ER doctor started compressions until our EMS arrived and took over. The patient was unconscious, apneic and pulsus on arrival. The patient was cyanotic and pupils were equally dilated. Glucose was placed and compressions were started to continuous compressions. Attempted an intubation, but was unsuccessful, so moved to the gel and continued to bag the patient through that. IO was established in the left humeral head and set up with epi that was given for 3 rounds. Sodium bicarb was given as you're pulling into the hospital, and the last rhythm on the monitor was PEA. The ER was called for trauma alert, and basically no change in the patient's status until they, like throughout the time that you were caring for them. So this is kind of pulled from like that assessment section in terms of kind of like what other things there were that were charted. So the initial kind of contact, basically no blood pressure, no pulse. The second vitals were that there was a pulse of 64. You know, there was no, in the narrative, there was no documentation of the PEA rate. And we'll talk about why that's important specifically for a traumatic arrest. But, you know, for this patient, if it is PEA of 64 in the case of a traumatic arrest, then that patient does need to be transported. The cutoff is less than 40. And it seemed like you guys transported basically all these traumatic arrests that we're going to talk about. So I'd be interested to hear kind of your thoughts about the decision making around that. Otherwise, the interventions that were done here, so IO in the humeral head, there was documented that there was bilateral chest, or at least 2 chest decompressions. It wasn't in the narrative, but it was up in the kind of like interventions section. So it got done, which is great. I assume this was bilateral, but the charting didn't have kind of like laterality to it. So one thing to consider, either put in your narrative that you did bilateral needle decompressions, and perhaps even put the location. We'll talk about kind of your options there. But it was up there in the intervention. So really good that that was done. You got the airway, totally appropriate to attempt an intubation when that was unsuccessful, going to the gel. And so that was documented well. And then got the medications that were kind of indicated. So again, the only thing here is that, you know, I had to look to find that chest decompression, and it was done, but it just wasn't in the narrative section. So when thinking about kind of traumatic arrests and thinking about this case, you hit the nail on the head with, you know, pretty much all the things that need to happen. We'll talk about kind of the medications and why you actually don't need to kind of do those. But the point of a traumatic arrest as opposed to a medical arrest is that, in theory, right, what that patient needs who's had a traumatic cardiac arrest is a surgeon, right? They need a surgeon to drill a hole in their head and relieve a brain bleed. They need a surgeon to cross-clamp their aorta and stop bleeding into the belly. They need a surgeon to fix their femur fracture that's bleeding out into their thigh. And in theory, right, these patients are more than likely in some sort of hemorrhagic shock, and that's what leads to their cardiac arrest, which is totally different from the MI or respiratory patients that go into cardiac arrest. And so the goal here is for you to, as quickly as possible, while you're on scene, do the things that you can do to potentially reverse causes of traumatic cardiac arrests, and as quickly as possible get that patient somewhere where they can see a surgeon. So when it comes to kind of how to go through that, we're going to talk through the March algorithm and that stuff in a second when we talk about another case. But you want access, you want to start giving some fluids, which was done in this case. You want to needle decompress both sides of the chest empirically if they're in cardiac arrest and it's trauma. You want to make sure that you have some sort of control over their airway. It doesn't have to be an endotracheal tube. It doesn't have to be an LMA. If bagging is what you've gotten and it's effective, that's okay. But an LMA certainly is super easy to kind of throw in for these patients. And then unfortunately, these meds just aren't going to do all that much to help them. And again, that's because the most likely reason that they arrested is they just don't have blood volume. And you guys don't have blood to give back. And
Hey,
that's
Doc.
Yeah,
Hey, Doc.
Yeah.
I think there's an important distinction that needs to be made, though,
Yes.
is that there's a difference between a traumatic arrest and a medical patient who has suffered trauma. And
Exactly.
a lot of our patients, and Lieutenant Connolly and I have been on this run before where, hey, a person has a seizure and then they hit multiple cars or they drive off into I-75 and, then they get hit. They've sustained trauma, but, we have to go down a kind of a decision tree of whether we're doing medical or whether we're doing trauma. So I think there's a distinction where if this guy was shot multiple times, 100%, they need blood or some type of perfusion because the drugs have no way to circulate around the body. But a patient who has sustained trauma might not necessarily be a traumatic arrest, correct?
Yes, and that's where, again, like you said, decision making on the scene is sort of what matters. And absolutely, like single car, middle of the day, no clear reason for why this accident happened. Like person just drives into a tree. Like medical should be super high on your differential, right? Like what's the likelihood that that's going to happen? And solely be trauma. That person could have seized, that person could have had an MI, absolutely. A situation like this, it seems more likely, especially if that person got thrown out of their vehicle, that trauma is going to be on the top. I'm not mad about epi, like it's not hurting anything, but if you go down the traumatic cardiac arrest, whether it's blunt or penetrating trauma, it's not necessary. And what I would say in this situation for this particular patient, who sounds like probably intoxicated with you, I guess, or with a death wish, which he got, with him driving the wrong way down the highway and all that jazz and kind of being ejected from the vehicle, that I want to make sure that people are focusing on that traumatic management, because if there's a tension pneumo that you can relieve quickly and simply, and you don't do that, then you're never going to make any headway, no matter what else you throw at the patient. So that's why kind of all of these things that were done up at the top here are super important. And as a note, if they're in a shockable rhythm, then shocking is the same whether it's traumatic arrest or medical arrest. So if they're in a shockable rhythm, you're gonna shock them all day the same way you would if it was a medical arrest. But yeah, if you get to the point where you give them these, the cardiac arrest drugs, that's fine. But just again, make sure that you're paying attention to and dealing with the reversible things that you can before you kind of go down that road, especially if, there's multiple people on the scene or you're short of hands or anything like that. But again, I think this was really, really nicely done in terms of how it was managed. So those were two MVCs, or one medical person on the highway and then an MVC. This is a sort of strange case, and I think is again somewhere where it's worth highlighting, kind of focusing if you have signs of trauma on making sure that you manage them. So this is a dispatch to an unknown age female who is bleeding and unconscious. There are lacerations to the left and right side of the neck, and she's pulseless and apneic. Basically, a homeowner walked out of his car, found female of unknown age underneath the vehicle, called 911. No identification on the woman, no known time for how long she's been down. A good kind of notation of the temperature outside. So I think that's helpful, right? If this was the middle of winter, our management could look very different. And then they found what appeared to be a small, like 2.5 or 3 inch kitchen knife when they arrived. On arrival, patient's apneic, unresponsive, and in the care of the engine. CPR was started, and then the patient was placed on the Lucas device. She had pale, cool skin with no signs of rigor or lividity, and she had 1 large laceration to the right side of her neck, partially where the jugular is, and then 3 additional separate stab wounds to the left side, and a large amount of blood, and there was kind of a trail of blood across the street. The patient was unresponsive with a GCS of 3, with absent lung sounds. Once the Lucas was secured, patient was placed on a backboard and moved to the cot in the back of the medic. Defib pads were placed and verified asystole. Got a blue IO in the left tibia and hung some normal saline. Got 2 rounds of epi and a size 3 eye gel that was confirmed with capno, which is fantastic. And then she was bagged through that while doing compressions and on the way to it did not appear that these wounds were still like actively hemorrhaging. So again, kind of this is just the protocol so that you see it, and then we'll talk through some more assessment things. But again, this is adult or pediatric. If there's signs of either blunt or penetrating trauma. And I always like to put this in here in terms of if you have a traumatic arrest patient, there are a few situations where if those injuries are not compatible with life, you do not need to initiate resuscitation. So that's if their head has been chopped off or half their body has been ripped off, if they are burned beyond recognition, if there's obvious signs of death, which we've talked about before and was documented that those things were not present for this patient, which was helpful. And then there's a note here that isolated penetrating trauma should rarely be considered incompatible with life. So my point to kind of including this here is this has to be like so glaringly obvious that this patient cannot live in any realm of your imagination for you to not initiate resuscitative efforts on a traumatic arrest patient. We often talk about how electrical injuries are not kind of included here. I will say that I have seen a case of someone who was electrocuted by high voltage wiring, and it was documented, you know, there was a pool of blood, but like the whole half of the body was so burned, and there were these gigantic holes with like no blood even coming out of them. Like, so yes, it was an electrical injury, which is usually an exclusion here, but they were able to kind of make a case to not initiate resuscitation because there were so many other obvious kind of facets that fit these criteria. If you have someone who has a bullet hole through their head, even if there's brain matter pouring out onto the sidewalk, that should not be considered incompatible with life. If you have someone with multiple penetrating chest wounds, that should not be considered incompatible with life. So just as a reminder, you know, it's really these first two, like that person has to be so clearly and obviously past the point where any surgeon or any physician could help them for you to not initiate resuscitation. And then kind of moving on through the protocol, what we talked about in the first case with airway management, access, fluids, and bilateral needle decompression are really sort of the core tenets of this. And then once you are assessing your rhythm, if you have asystole or PEA less than 40, you can actually call medical control to terminate resuscitation on the scene. If PEA is over 40, like might have been the case with that first patient, depending on kind of how I read that documentation, then that patient should be transported. And if they're in any kind of shockable rhythm, then you should shock them and transport them. Do you guys tend to call for traumatic arrests, or do you tend to transport them regardless?
So,
It's a mixture.
Okay.
yeah,
I know there's cases where it's been done both ways, but I think it really has to do with provider comfort.
Yeah.
Right, so, certain people are more likely to just make that call and terminate in the field than others.
And I think that's totally reasonable. I just wanted to make sure that kind of we talked about this and kind of where your decision point is. Again, is that PEA rate of less than 40. And if you have any suspicion that it could have been medical, there's not, you know, no one at Westchester is gonna be mad at you that you brought someone in because you thought they might have stroked or you thought they might have had an MI as kind of the reason for this. And then, oh yeah, they crashed their car and have internal bleeding also, right? But if you're fairly certain that this is trauma all the way, and you're in either asystole or PEA less than 40, there really is, there's no kind of coming back from that. And so you can call for termination orders if you're comfortable with it. All right, this is just for fun. And to kind of like go back to this case, right? So this was a woman who there was blood trailing along the ground, obvious stab wounds to the neck. and kind of obvious signs of hemorrhage. And so just a reminder that it can be fairly surprising, but penetrating trauma to the neck can cause pneumothorax. So this is just a fun case report of a stingray, which like hopefully none of us are going to die by stingray to the neck. It sounds awful. But this was a patient who was stung by a stingray, and the barb was long enough that it kind of clipped the top of the lung. And that apex of the lung comes right up under your clavicle, right? So it's not all that far. Even those small little switchblades can do it. And in the narrative of that case, they did document that there were absent lung sounds on both sides. But I didn't see either in the narrative or in the kind of interventions for that case of anyone attempting needle decompression. So that is the one thing that I would definitely want added to that patient's care. And remembering again that the traumatic arrest protocol is blunt or penetrating trauma. And so again, just to like quickly needle decompress this patient's chest. Would it have changed the outcome? It seems unlikely, like the wounds had stopped bleeding and all this stuff, and she was in asystole. But protocol wise, that's the other thing that should have been done in that case. This is a picture of that case report. And so like this wound on the outside, right, is not particularly obvious. But it is not a long distance for you to get from that lower part of the neck to the apex of the pleura that sits right under the clavicles here. And so it's not great, but this is where this large right-sided pneumothorax is. The lung is kind of sitting here, and this is the lung. And then all of this space is all just air, right? So don't be fooled by what could be kind of a small wound. You don't want to, we'll talk about this, but you're not going to go decompress every single person that gets stabbed in the neck, right? But multiple stab wounds to the neck in cardiac arrest. Think about the penetrating, like the impact of that penetrating trauma. Think about the traumatic cardiac arrest protocol. And again, access, airway, hemorrhage control, and then needle decompressing both sides of the tenets of that protocol. Any questions about that case? Not even the peanut gallery.
The patient lived?
That patient did not, no. Where's my follow-up for that? Sorry, I'm working on two computers. So she was a trauma stat. They got a unit of blood, got a trauma cath, and still had cardiac standstill on ultrasound, and so stopped resuscitative efforts after that. They did decompress the chest on both sides in the ED. I didn't see, I don't know if you remember, if they commented if there was a rush of air or anything for them. But you know, obviously she can very well have hemorrhaged just from the jugular or the carotid, depending on, you know, what got hit. Or she could have had tension, you know, tension pneumothorax. Either one of those things could have killed her. So yeah, in the ER, they kept doing high quality CPR and then decompressed and gave her blood. And that's about it.
She was really interesting because she had been seen multiple times leading up to this for like disassociation and stuff like that. So like the week prior, she was saying that she felt like somebody was taking her over.
Interesting.
Yeah.
Maybe they did. Yeah. All right. Creepy. All right. Okay, so this is a 56-year-old who was a motorcycle versus car. She was unresponsive, GCS of 3, laying on the left side with a pedestrian. She was moaning but not able to speak, appeared pale and cool, breathing spontaneously, and did have a radial pulse. The patient was the driver of the motorcycle and was not wearing a helmet. So PSA to wear your helmets if you drive a motorcycle. On initial assessment, she was noted to have an obvious left tib fib fracture with detachment at the ankle, abrasions on the top of, oh, sorry, it's a guy, on the top of his head, blood in the nostrils and in the left ear, and pinpoint pupils. C-spine was secured, clothes were stripped, and the patient was exposed. Both legs were splinted after confirming that right-sided fracture. And there was no kind of obvious issues on the patient's back when rolling onto the backboard. It did look like there was a contusion of the abdomen, but the abdomen was soft, and I don't know what no pulse is present in the abdomen means. But if you're sort of trying to palpate for like an enlarged aortic pulse, maybe. The lung sounds were present but diminished bilaterally. Left leg bleeding was uncontrolled, so a tourniquet was applied on the quad, and that controlled the bleeding. Make sure you always note kind of the time, at least on the tourniquet or when you do handoff for those tourniquets. During these interventions, we called to Westchester. The patient was moved to the cot and secured, had an oral and nasal airway suctioned, and continued to bag the patient and support their breathing, and had capnography with the bag. So again, you can put capnography on anything, right? So even if you're just doing bag valve mask, go ahead and attach the capno, and that'll give you good feedback as well, like was done in this case. Got IV access, got a fluid bolus started, blood glucose was 520, EKG was sinus tach, and the patient's hands were noted to be cold, and the pulse ox was not providing consistent readings. Pupils were assessed and were equal and reactive to light, and the patient was transported to Westchester. During transport, the patient's heart rate noted to decline from the 90s to the 70s. Attempted needle decompressions, but landmarks were difficult or unable to locate, and so it was avoided. Patients still remained compliant with BVM bagging. Just prior to arrival, radial pulse became absent, and monitor noted to show heart rate in the 50s. Carotid pulse was palpated to confirm heart rate in the 50s and was present but weak. They were moved to the trauma bay from the cot to the bed and secured, and while report was being given, the ER staff noted there was no longer a pulse and compressions were started. At that point, transfer basically, the resuscitation continued and the patient's care was transferred. These were the vitals from this patient. So initial blood pressure of 154 over 127 with a heart rate of 114, respiratory rate being assisted, and then repeat vitals from 155 over 107 with a heart rate of 81. And then the final ones, as were documented, a blood pressure that was not able to be obtained and a heart rate of 52. So really good documentation of kind of how this patient progressed. And kind of continuing that reassessment. It is a little bit difficult to kind of know exactly in this moment what might be going on, but certainly with a high blood pressure and progressive bradycardia in an unhelmeted bike rider, some sort of head trauma is certainly on the differential. You started with tachycardia and obvious signs of trauma, both with a open fracture and with bruising on the abdomen. So hemorrhagic shock is certainly possible. With those diminished lung sounds, I think it's also reasonable to think about the possibility of chest trauma and pneumothorax. The key kind of differentiator for whether or not you needle decompress, well, there's a couple of situations. So the first is, have they arrested? If they've arrested, then you don't really have to think twice if it's trauma. You're going to decompress both sides. If they are not in cardiac arrest, then you need to decide, does this person have a tension pneumothorax, which really kind of speaks to the vital signs in this situation. And I think it's tricky with this patient, right? You have a worsening heart rate, they're progressing toward cardiac arrest, and then did actually arrest. But actually right before that happened had a normal blood pressure, which if it's a tension pneumothorax, probably shouldn't really be happening.
About those blood pressures, we've noticed with the fours, I'm sure everybody else has, is if you have a patient who could likely have a low blood pressure and you get a high blood pressure like that with a narrow pulse pressure, they're probably in the 50s, so do a manual. Because that number is unreliable on a low blood pressure.
Yeah, so this 154 over 127. Yeah, so when you're seeing that, definitely be thinking, is this just a kind of a result of your equipment and not a real blood pressure? Again, if this is head trauma, certainly could be. If this is hemorrhagic shock, then it's unlikely to be, right? And so getting data that you can fully rely on is important, so I appreciate that comment. So again, several reasons why this kind of could have progressed. And just a reminder that if someone has a simple pneumothorax with no hemodynamic instability, that is not an indication to decompress. And part of that is, right, it's not a zero risk procedure. It's a simple procedure. It's a relatively safe procedure. But if you put it too low, you can't put it into the liver or the spleen. And so it's not zero risk. So we really want to do it for the patients where it's going to have an impact. And those are the patients that have tension physiology. So definitely a reasonable thought with kind of like what was happening with this patient. So now we've talked about kind of a couple of different cases of traumatic cardiac arrests and kind of thought process for a couple of them and what the protocol shows. So I just want to touch on a couple of other things. The first is the March algorithm, which hopefully you guys have heard at this point, but it sort of replaces the ABCs of when you're medically assessing a patient. So M is for massive hemorrhage, A is for airway, R is for respiratory, C is for circulation, and H is for hypothermia or head injury. And some people will also add in hypoglycemia there, right? Like why might a person be altered? So for massive hemorrhage for this patient, about halfway through the narrative was documented that they got that tourniquet on. If you're following the March algorithm, that's actually going to be one of the very first things that you do, right? If there's external hemorrhage that you can control either with pressure or with wound packing or with a tourniquet, that's going to be right up at the top. And again, that's because in trauma, blood loss and hemorrhagic shock are the most likely thing to kill a patient, right? We've discussed about the fact that it's not the only thing, but the most likely thing. So that's M for massive hemorrhage. A is for airway. So again, for this patient who was needing to be bagged, that's one way to secure it. I think they did put in an OPA, if I'm remembering correctly, but using your airway adjuncts to kind of help you with that. And then if he's really GCS of 3 and can tolerate an OPA, that patient would probably also tolerate an LMA. But if it's working, you don't necessarily have to fix it. R for respiration, so that's where your needle decompression comes in and kind of that assessment. And then C for circulation. So especially in a patient with an obvious extremity injury, checking and documenting pulses in all the extremities is kind of good practice to do. And that's why we're getting access and why we're giving some fluids in these patients, because it's the one thing that we can kind of do to act on their circulatory system. And then H for hypothermia and head injury. And again, hypoglycemia sometimes gets added to that as well. So making sure to keep the patient warm after you've exposed them. Interesting.
Unconscious person.
How you guys? See ya.
So hypothermia, what I was saying is just make sure that after you've got that person exposed, that you're making sure to keep them warm whenever possible. And then the next thing that I noticed kind of in the narrative documentation of this case is there was a slight discrepancy between the GCS that was documented and then some other comments about the patient's mental status. So it was documented as GCS of 3, but also that the patient was kind of moaning intermittently. And so that person would get a point for probably either, 2 or 3 on speech, depending on what they looked like. So if you want to go the simple way, which I'm all about, and want to use ABPU, you absolutely can, right? Are they alert? Are they responsive to verbal stimuli? Are they responsive to painful stimuli? Or are they unresponsive? It's simple and really pretty reliable when it comes to kind of comparing it to a GCS. If you're going to use the GCS, though, make sure that kind of every aspect of it lines up. It's easy enough to say that if someone's unconscious that they got a GCS of 3, but when you assess them and cause them some pain, if they're gonna kind of move or moan or do something, then you got to adjust that. Okay, so I just wanted to put this up here as a reminder, and kind of just pick that out from that documentation. All right, and then where are you needle decompressing? So I'd be interested to know kind of what people are going for here, because it's definitely changed, at least in the hospital setting. And I think recommendations are kind of cycling through to the pre-hospital setting to start using the anterior axillary line in the fifth intercostal space. The classic teaching, right, is the second intercostal space at the mid-clavicular line. And so you're feeling for the middle of the clavicle down 2 rib spaces and going in that space. It's safe on both sides. I mean, yes, you can go low, but you start to run into kind of breast tissue in a woman or the nipple, and people usually stop, right? So you can go low, but generally it's a safe place to go. You can have patients that have a ton of subcutaneous tissue and you just can't get deep enough in this location. So it certainly is possible. The reason people are starting to go ahead and needle decompress in this anterior axillary line, which is more on the lateral chest wall, is that that's where a chest tube's gonna go anyway. And again, it's a pretty reliable space. It is very easy to go too low. And it's very easy to be kind of off the mark in terms of where on that axillary line you are. So a good trick is to kind of put your fingers under the armpit, and you're basically going 4 finger breaths down, and you're staying on that anterior line. So if you have your hands down at your sides, it's where the front of your arm would be. Okay, you're staying away from going further posterior to that, because then you start to run into your nerve plexus and your vessels and all that kind of stuff. And you want to stay away from going too low, because if you go too low, like I said, you can hit the liver or the spleen, depending on what side you're on. So obviously, if you have gigantic hands and it's a small patient, that 4 finger breaths is not necessarily going to apply. The other thing that can be helpful is it's right at nipple line. And so if you are going below nipple line, or you're going below kind of the mammillary fold, that means you are too low with this needle and needs to kind of reassess. So either one is fine. Again, a lot of times in the hospital, they're moving to this kind of lateral placement, but just make sure, no matter which one you're doing, that you are paying really close attention to your landmarks and kind of be wary of the risks to doing either one of them.
So Dr. Richards and I are actually assigned this protocol for review this year.
Yeah.
And we're actually flip-flopping the preferred location. So
Sweet.
that still has to go back to the committee for approval, but you might see in 2025's protocol that the anterior axillary line is the first preferred location.
So this one, the lower one on at the 5th rib. And I think there's a decent amount, like, I can't really see a good reason why they won't approve that. I think most people are starting to teach that. You know, everyone always has the test question answer ready. You know, someone says, where do you decompress? Second intercostal space, mid-clavicular line, right? Everyone knows that test answer, but it's a little bit more difficult anatomy-wise to kind of get it right. And again, with like the body habitus of a lot of our patients, is sometimes just unsuccessful because you just simply don't have a long enough catheter. So that's super helpful. Thanks, Lauren. Mm-hmm. All right, and we already talked about kind of indications. This is the protocol for tension pneumothorax. And so some of the markers of tension physiology that we sort of mentioned before. So I just wanted to remind you that there is, on its own, outside of any of the traumatic arrest stuff, on its own, there's the protocol for tension pneumothorax. And this is the part of the protocol Lauren's talking about. For kind of the follow-up on that patient, the patient was pulseless, got CPR, and they actually did do an ED thoracotomy. So they started by just just venting the right side of the chest, and then tried to intubate the patient, but it was really tricky. The reason it's important to intubate these patients that are going to get a thoracotomy is that you actually kind of intubate deep, so you're only giving breaths to the right lung, so that when the surgeon goes in and does this gigantic cut down the left side of the chest and splays open the rib cage, that they're not dealing with an inflated lung right under the rib cage. And so it took a couple of attempts to get that intubation, but after that was done, the patient had a thoracotomy. What they do there again is fillet open basically the left side of the chest, put a clamp on the aorta. So if there's anything bleeding below there, whether it's a vessel in your belly, your aorta lower down, something huge in your leg, basically you're not continuing to lose blood to that location. So that's why they do that. And then you literally perform cardiac massage and like do CPR within the chest. So that was done. They had some trouble getting access, but were able to get a little bit of blood. And then as they kind of continued for 20 minutes, they elected to call time of death based on kind of the total amount of time that this patient had been unresponsive for. So again, certainly possible that this was all kind of intracranial, or that whatever blood loss there might have been into the leg or the abdomen was just so significant that there was no kind of coming back from it. But they weren't able to find, like a huge bleeding vessel within the chest or anything like that. It's super important. Again, let's go back actually to the documentation for that case. So this timeline of how the patient's heart rate changed when they lost pulses, this is critically important for the ER to know when they are deciding about whether or not to do an ED thoracotomy. So if you are reassessing your patient and they arrest and you're still 15-20 minutes out, that patient is not going to be a candidate. If it's 5 or 10 minutes out, that patient's going to be a candidate. So kind of describing this and being able to tell in your handoff super succinctly, lost pulses as we're coming down the drive, lost pulses 5 minutes ago, 10 minutes ago, whatever it was, that is really critically important to the trauma team as they're deciding what intervention they're going to do. And I don't know if any of you have ever stuck around when they choose to do an ED thoracotomy. It's not all that frequent, but it's pretty impressive. It's a bit of a Hail Mary. There's some survival with it, but it's a pretty impressive procedure. So again, this timeline, and this was documented really well for this patient, but this timeline is really what's most important to the trauma team. All right. Let me see if I want to do this case or just go to the last one. I would just go to this last one. Okay, cool. So we're done with all the kind of like hardcore trauma. And again, you saw a ton of it over the last 2 months. And it's, warm weather, people are out, people are doing crazy things. So you're just going to see more of it as the sort of trauma season gets underway. So hopefully going through some of those protocols was helpful for you. I'm just going to do kind of a quick teaching point on extremity trauma, and then we'll be all set. So this one was dispatched to a scene for an injury. The patient's lying supine on the ground in the basketball court, surrounded by other players. Alert and oriented ×4, breathing normally but diaphoretic and guarding his left knee. He states he was playing basketball when he collided with another player on the knee, and he instantly went to the ground in pain. Sort of an interesting mechanism, right? He didn't land directly on his knee. He didn't like plant and twist his leg. He actually like slammed into someone and then went down. So it's a little bit of a different mechanism than you might typically encounter. No neck pain, no back pain, no head pain, didn't hit his head, didn't lose consciousness, all super appropriate things to ask and document. Assess the left knee, it was bent and the area around the patella appeared to be deformed. There was pain on palpation of the knee, and distally he had good pulses, but his pain was 10 out of 10. An air splint was attempted to be placed, but due to the patient's leg position, the splint was unable to be effectively applied. got an 18 gauge, got some ketamine, rolled onto a sheet, and got some other folks who were around to kind of help lift the patient, got him to the cot, and then got him transported to Westchester. So obviously you guys are familiar with using vacuum splints, right? They are pretty moldable, but for a patient like this, where their knee is already bent and you're worried about the knee or the patella, you really don't want to try to straighten the knee at all. You really want to kind of splint it in that position. And usually they're going to be probably at like 30 or 40 degrees, something like that. And so trying to get your splint to kind of cooperate so that you can splint in that slightly flexed position like is here, is really probably what's most helpful, because straightening that leg is gonna, one, be extremely painful, and may not be appropriate depending on the type of injury that the patient has. Great documentation of PMS. The only thing I might like to have seen is, once you got him up and moved and there'd been all that jostling without any kind of splint on, did you still have good PMS after, right? So before and after, and actually it was documented, sorry, PMS recheck without change. So I take it back. So always document that. So no matter what your intervention is or what you do to the patient, make sure we're checking kind of before and after. And then splinting whenever you're able to. So this was this patient's x-ray. And this is the patella all the way up here. This is supposed to be here. And let me make sure. I don't know if I can change the pointer. Love it. Look at this laser pointer. So here's the patella, and it's supposed to be down here along this kneecap, like overlying the knee right here. This is a lateral shot, so this doesn't show that it probably was also displaced laterally to some extent, because the ER thought that it was kind of both high riding but also displaced. So they ended up reducing it back into the midline. But then even afterwards, which is this x-ray, even afterwards, the patella is still super high. So at this point, they can now get the patient's knee straighter because they've gotten it out from where it was dislocated. But that patella is supposed to be hanging out like down here. So this patient had a kind of interesting diagnosis, which is that they think that he ruptured the patellar tendon up here. And so when you, the patellar tendon down here. So when you break that tendon, you kind of get unopposed action of the quad muscles, and it like yanks up on the patella and kind of like keeps it up high riding. So that certainly can happen with any kind of like direct hit. Oftentimes it's someone who like goes down on their knee or runs into something. So I don't know what the body habitus was of the person that he ran into, but pretty impressive to have ruptured this tendon down here, and then also dislocated the kneecap. All right, so just a quick comment about patellar dislocations. So most commonly, they're going to dislocate to the outside or the lateral aspect. So this is the patella of someone's left knee kind of hanging out to the side here, and it's supposed to be going up and down the middle. So most commonly, they're going to dislocate laterally, and this is what it looks like. So again, this is now an x-ray looking from front to back at the knee, and that patella is supposed to be sitting right in the middle in that groove of the kneecap, and so it's all the way off to the side. That is super, oh sorry, I should have warned you that there's a gross picture. I think this is the most disgusting picture on the internet. But anyway, that is, a patellar dislocation is very different from a knee dislocation. So I like the documentation that like the patient complained of a knee injury and there was sort of some deformity in this area, which is a totally reasonable way to describe it. A knee dislocation is when you rupture some or many or all of the ligaments in the knee joint, and literally the femur is dislocated from the tibia. And it's a much more severe injury. It's excruciating, and it's not a simple fix. And so this is what this patient might look like, where the femur is literally kind of fallen off the tibia, and that whole knee joint is dislocated rather than just the kneecap. And in that situation, there's a lot of different ways that that can happen. It's usually a pretty high mechanism of injury because you have to rupture, like I said, usually several ligaments for this to occur. But there's lots of different ways and kind of directions and stuff that it can happen, and is a pretty gnarly injury. So that's pretty much what I had for this presentation. Anyone have any questions about what we talked about today?
Hey, real quick, do you have the follow-up from case number 1?
Yes. That was a medical arrest, right?
Yeah, it's the 59-year-old.
Yeah, so she was hypotensive when she arrived, had pretty poor ventricular function on her bedside echo, and kind of got progressively more bradycardic and hypotensive and rearrested. Got some epi and put on an epi drip and required CPR to be restarted in the ER. She was in PEA while she was there. They did give the 1 dose of amio with a report of there having been BFib on scene, like right at the beginning, and also got some more bicarb. And they were able to get ROSC after a few more minutes. She had pretty bad looking EKG after getting ROSC, but not consistent with kind of a standard STEMI. And she rearrested again, and got ROSC again, but at that point, kind of really wasn't doing all that much in terms of her responses. And so they got a bunch of imaging to figure out kind of what they were dealing with, and talked to cardiology about whether or not to go to the cath lab, but did not end up going. The only thing that came up on her imaging was maybe a small splenic lac, so kind of unrelated, more than likely, to the cardiac stuff. And I'm not sure exactly the timeline, but after a while she started having seizures and had a pretty bad looking MRI, so the family decided to make her comfort care. So a pretty rocky ED course, but survived to the ED, survived to admission, but probably had really pretty bad cardiac disease underlying all of it.
Thanks.
Yeah. Any other questions? All right. Well, again, thank you guys for letting me hang out and work with you this year. I had a ton of fun. If there's ever questions that come up, especially about peds things, Dr. Richards can always get a hold of me. Woody can always get a hold of me, but it's really been a pleasure. So thank you guys.
Thanks so much.
Yeah. Have a good day.